This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
The microtransponder Vivistim paired VNS system is intended to be used to stimulate the vagus nerve during rehabilitation therapy in order to reduce upper extremity motor deficits and improve motor function in chronic ischemic stroke patients with moderate to severe arm impairment. Do not use if you have had a bilateral or left cervical vagotomy. Risks may include, but are not limited to, pain after surgery, hoarseness, bruising, swelling, coughing, and throat irritation. While not observed in the Vivistim studies, infection leading to explant is a risk associated with any device surgery. For full safety information, please see www.vivistim.com/safety. Individual results may vary. Hi, Dr. Kimberley, and welcome to the No Stroke Podcast.
Hi, thanks so much for the invitation.
Certainly. So, as David and I typically do these morning recordings, I know we caught you a little off guard last night saying, oh, is this going to be a video? Because you planned to go get your workout in before. And it fits the theme of our previous episodes all around fitness that we've been discussing. So maybe before we get into the formal episode, walk us through what was your workout this morning?
So I'm a trail runner, and I also do CrossFit. So those are my favorite activities. Been doing CrossFit for about 5-6 years, and have gotten quite addicted to it. It's my whole friend network is at the gym. So it also, which is one of the sort of secrets to exercise consistency, right? Is if you can engage with your friend network as well. I also have a big group that I run with. We do trail runs together. So yeah. Very
good. Well, I'm happy to hear, and thank you very much for making a quick workout this morning, getting back to us. So, let's kind of take a step back and walk us through. You've gotten into a fantastic position, with MGH and running the brain lab. Some really cool work happening up in the Boston area that you're leading. But for our listeners, walk us through a bit of your background. How'd you kind of get to where you are today?
Sure. So I started my professional career as a physical therapist, and practiced for a number of years, primarily in neurologic disorders, treating people with neurologic disorders, stroke in particular. And I was frustrated by the lack of evidence that supported a lot of what we did as rehabilitation providers. There was, at that time, a lot of, I call it guruism, where there was a theory and a person who had a strong theory as to how to make people recover, but there was no real science and evidence that underpinned why we were doing one approach versus another approach. So that really propelled me to go back to get my PhD, to understand how the brain actually recovers and how to facilitate that recovery. So my PhD work involved neuroimaging, where we were able to look functionally at the brain. It's called functional neuroimaging. So we were able to see, how does the brain actually recover when you do certain kinds of rehabilitation. And during that time, it was an explosion in the late 90s, early 2000s of understanding that the brain has immense capacity to recover, to actually change the way it's organized, to be able to make learning, say in a healthy brain, or in the case of somebody with stroke, to actually reorganize, to optimize how to make up for the damaged neurons that are gone because of the stroke. So that concept is called neuroplasticity. I then became quite interested, in addition to being able to look at how the brain recovers, to use the concept of neuromodulation. So this is how do you impose things onto the brain to help them facilitate a better kind of recovery. So in addition to rehabilitation that we know helps drive changes within the brain, can we add something on top of it to facilitate that positive recovery? So that's sort of been my journey throughout the last 20 years.
Well, thank you for that intro, and thanks for joining us and greeting the day early with us here. It's always great to have someone on that gets their workouts in early. I was looking and reading a little bit more about your sort of your career journey, and I always like to add something personal. You told us about your exercise history, but in terms of like your career achievements, I did notice that you do have a number of awards, but one I do want to mention, because we've had a variety of physical therapists with roots in rehab and OTs, and you were actually named, you had a pretty prestigious award being named the Catherine Worthingham Fellow of the American Physical Therapy Association Award back a few years ago. So congratulations on that. And I really like to dive a little bit deeper into some of the challenges that we typically see with rehabilitation for chronic stroke. Could you comment a little bit before we get into specifically around the topic for today of paired VNS therapy?
Yeah, this is a passionate topic for me, so I'm really glad that you asked the question. So stroke care is, in my opinion, basically broken in the US. There's so many problems with it. People have a stroke, and if they're lucky, they get into a stroke center, acute care hospital, and they have great care. And we've made a ton of advances scientifically, medically, about the acute management of stroke. And then they discharge from their acute hospital, and where they go after that is a bit random. It has to do, you would think that it should be driven by their status as to how much rehabilitation they need and can tolerate. But it is not. It is driven by who their insurance provider is, how crowded the rehabilitation hospitals are, the state that they live in, a number of other factors. And so let's say they're lucky and they're able to go into an intensive rehabilitation hospital like Spaulding Rehab, like we have here in Boston. That's great. They get to stay there for a few weeks, and then they discharge to home, and then they're probably doing some outpatient therapy. But the problem is there's no one that's really in charge of their care from that point on. They have a neurologist in the acute hospital, and maybe they have a physiatrist in the rehab hospital. They have a physical therapist and occupational speech therapist that they saw in the inpatient, then different ones in the rehab hospital, and the different ones as outpatient. And there's sort of no one that is helping to really manage their care throughout their lifespan, because this is a chronic disease. So similar to somebody who has Parkinson's disease, they have a movement disorders neurologist who will manage their care for the rest of their life. Stroke doesn't have this person. There's not a clear model of who they should be interacting with to come back in every year and have their checkup and really have somebody who knows about chronic stroke care and can manage all of the symptoms that they are experiencing, which are diverse. It can be sleep problems. It might be anxiety or depression. It might be, now they're getting some secondary problems in their back and hip because they've been walking with a limp now for several years. And they also don't have any way to understand what's new out there. How should I be, my spasticity, my tone is increasing. What should I be doing related to that? They don't have anyone. Most people with stroke, they discharge from wherever the therapy is that they've had, and they go home and they never engage with stroke specialists again. It's a huge problem.
Yeah, I think we could have another 300 episodes on the issues happening within stroke care. And you hit the nail on the head, right? It's that transitional care, and there, we've heard from many survivors and care providers, just the feeling of being dropped off the edge of a cliff when you leave that hospital. And I think it's also, you talked through, some of these key things that have been happening in stroke care. So now more in you spoke to, and it's pretty evident, the innovation and the funding that's going on in the acute setting. But now kind of thinking more in some of the work that you've done, you mentioned neuroplasticity, like there's so much now happening, right? And I think what we've seen in previous discussions as well, from researchers and people in the field who are innovating, coming up with these new ways to really drive outcomes. It's starting to give a sense of optimism, right? That stroke always used to be you've had this life event, and now you're on a certain path, right? And it's always been looked at in that vein. But there's so much happening in this field now where I think it is kind of giving that sense of hey, there's hope, there's optimism here that we can have folks recover, we can have them get back to work, we can have them have access to activities of daily living again. And one that we're gonna be focusing our discussion around today is a very common deficit for individuals who've suffered a stroke, right? Around 50 to 60% of individuals will come away with upper arm extremity defects, right? Where you mentioned it before, tone in one arm, and my own mother suffers with that. My mother, future mother-in-law, same thing, and there's different grades of it. But it's something that a lot of our stroke survivors have to overcome and put in work. And there's some great innovations happening now, which we're excited to kind of cover today. So with that, can you speak to the upper arm extremity defects itself, right? Like, and some of the work that you and your peers up in at MGH have been able to kind of bring to life with Vivistim and the new vagus nerve stimulation that's currently happening.
Yeah. So I think we're at a precipice within rehabilitation and neurologic recovery that there really is cause for hope, that there are some new novel mechanisms of engaging our body's natural ability to recover in ways that will help facilitate people to gain the ability to do things in their daily life, as you mentioned. And this Vivistim is one of those things, vagus nerve stimulation. So just to orient us, the vagus nerve is one of our cranial nerves. It happens to run down your neck, and it controls a whole bunch of things related to your heart rate, digestion, parasympathetic system. So that fight or flight reaction that people are aware of, it's on the opposite side. It helps to down regulate the system. But there are some fibers within that nerve that project to the brain. And that is why the mechanism of vagus nerve stimulation even came to be. So what we're talking about is an implanted stimulator. So there's a surgical procedure, and there's a little cuff that goes around the vagus nerve that is able to activate the 80% of the vagus fibers that go up to the brain with a little electrical pulse. So there's an implanted little pacemaker, and then this stimulator will directly stimulate the vagus nerve. So what is happening is when the vagus is stimulated, there is this release of neurotransmitters within the brain. So what are neurotransmitters? Neurotransmitters are like the brain's currency of how it helps to facilitate neural activity. So if you have more neurotransmitters that are being pushed out from neurons, you have more currency available for the other neuron to be able to take that up and then be excited. So more neurotransmitters and specific kinds help to enforce learning. So it's the natural mechanism that our brain does anyway when we learn new things. But the vagus stimulation helps to give that natural mechanism a boost. So the important thing to understand about vagus nerve stimulation is that it's essentially useless if you just stimulate and don't do anything. So we were talking about exercise this morning. If you had a vagus nerve stimulator and you were stimulating it, and this is in the context of stroke recovery, it wouldn't help you. You have to pair the pulses of the stimulation with practice. So in the context of upper extremity recovery, people have a hard time. Typically their arm is like this, and they have tone that pulls the hand and arm down, and they have a hard time opening up the hand in a precise and controlled way. And then they have a hard time with really fine dexterous movements. Lots of times shoulder motion is also impaired. So in vagus nerve stimulation, what we do with impaired VNS, what we do is we have people perform challenging repetitions of movement. So practice of picking up objects and releasing them and reaching and all of the things that are hard to do. We do that with the vagus nerve pulse. So what this looks like in operationally is you're in the clinic with an occupational or physical therapist, and you're practicing these movements, and the therapist is directing this pulse of energy that's stimulating the nerve that is then releasing these extra neurotransmitters. So you're practicing, let's say you're really practicing on picking up an object. Your neurons know how to do this, but they don't do it well. But when you give it extra neurotransmitters to help facilitate that neural activity, you help to strengthen that synapse. So the synapse is like how the neurons talk to each other. So you help to make that connection stronger. So as that connection gets stronger over time, you practice it again and again and again and again, it becomes easier and easier and easier. So the analogy of this we experience in everyday learning. Like I have a piano behind me. So when you first sit down to try to learn how to play piano, it's hard, and you have to think, and which that note means this finger, and I have to move, and right, it's a big brain process. And then you become good, you practice, and you learn, your brain learns these like shortcut pathways. And so you can just look at that string of music and your fingers will just move. That is the same process that we're talking about. But in this case, it's trying to get new pathways, new other neurons to come and come in and help with these ones that are really struggling. That's the concept behind paired VNS therapy.
That's a great explanation, and I loved how you worked in the music component to that, because that's, overcoming that initial friction and so the pairing that you talked about, the essential part of this is with exercise. As we often say, the best medicine after stroke. But I just remember early on learning about the vagus nerve and knew it as cranial nerve 10, and didn't, it's so amazing that it has a role in so many facets of health, really. But in this capacity, you mentioned that this gives you hope and kind of changes a little bit your perspective, seeing some of the results. I hope we can talk a little bit about the study that you recently reported on. I saw that you were at International Stroke Conference earlier this year, and you mentioned that you described this somewhat as a watershed moment for folks that might be struggling with you know, impairments in upper extremity, especially from ischemic stroke. Can you talk a little bit deeper about that?
Yeah, because we know that currently the best thing that you can do for stroke is intense exercise, intense practice, right? And so exercise is a hard word. Like people have different ideas of what an exercise is, right? But that means, walking. And actually, if we're talking about the arm, that means doing the thing that's hard and doing it over and over and over and over again. That will drive brain changes. We know this. Sidebar, currently in our healthcare system, most people do not get the kind of intense therapy that they need to actually be maximizing their recovery. That intense practice, different topic, but so that right now is something that everyone can go out and do immediately, is get therapy, figure out a way to be able to be practicing at a much more intense level, meaning you're doing it, you're really focusing on it. It's hard, but you can still do it. That's what I mean by intense practice. Okay, but why is this such an exciting moment? Because we have now discovered that there's this technology that we can do on top of what your brain already can do. And we can make it get there faster and better. So it can get even more benefit than you can get on your own. So in our pivotal trial study, which was the large 108-person trial that was completed in 2021, that showed that we had people everybody got implanted with this device, and it was completely blinded in that the treating therapist didn't know what group you were in, the assessing therapists didn't know what group people were in, and the patients didn't know, because for the most part you can't feel the stimulation when it's happening. So it was essentially a perfect blind. And then randomly the machine either delivered the real VNS or nothing. It had a few little pulses in the beginning just in case you could sense it, and then it went down to nothing. So it was a perfect blind. So everybody got the same intense therapy, and the control patients got better, which was not surprising, because 90% of patients with stroke are not receiving or doing the intense level of practice that they should be doing, that to maximize their recovery. So people who got the control intervention did get better. But the people who got the VNS with the control intervention, the VNS with the therapy, got twice as good. So they had double the improvement. So the reason this is so exciting, not just for upper extremity recovery, is that the concept underlying it of this facilitating the brain recovery with rehabilitation, the brain recovery that happens with rehabilitation. The reason it's so exciting is because the theory should not be local just to the arm recovery. And it's also exciting because the technology could be applied in other neurologic disorders as well. So again, that needs to be done. Those studies need to be done, but that's why I say I feel like we're on this precipice of rehabilitation going through a watershed moment, because there's technology that can be applied on top of what we do anyway, not replacing it. If you can't replace it, there's no little pill, you just get the stimulator and you're all good. You have to work at it too, but it helps. But my guess is that it's going to help everything get more better.
That's super exciting to hear. And I'm sure the audience responds, ISC, this, kind of going back, it provides optimism, right? Stroke recovery has always kind of had this, black sheep to it. And I think now we're at this point where there's some exciting things happening. Just specifically to the therapy that's provided right now. And like you said, there's so much potential here, but it just hasn't been studied yet, right? So say for a listener who might be interested in kind of finding out more about the current treatment that, just based on what's been studied right now, like what are some of the eligibility requirements for a survivor who might be interested in this therapy?
Yeah. So currently, the best candidate for this therapy that we know will match the criteria that we studied. So we want to have the people be as close to that same level of impairment, because that's the group that we know improved. So what does that look like? That is somebody who has moderate to severe hemiparesis. So meaning they have moderate to severe impairment in their upper limb. The way to sort of guess is about kind of where, if you're in that right range, is you want to be able to actively by yourself, can you make your wrist move a little bit by yourself, as in not with your other hand, but you can actively make that wrist move a bit. And can you make your fingers, any of your fingers, move a little bit actively? So sometimes people, their fingers can move because if they just relax, the hand will just sort of open. At this stage, my recommendation is that that's not the right person, that's not right. They're not ready for this yet. We don't know that it's going to work in people who don't have that active motion yet. That is going to be an area of study soon in the future, for sure. But right now, what we need is people that can participate in the therapy, meaning they have to be able to move those body parts a little bit so that we have something to work with, so that they can engage with that therapy to actively make that hand or wrist move. The other character, so that's like the level of impairment, or better, right, or more than that. The other things are related to personal characteristics. So this requires, as I think we've emphasized here, this requires a lot of therapy, and you have to be willing to go into the clinic and get this therapy 2 to 3 times a week, going in and working hard for an hour. Like you're going to be in there and you're going to be working hard for at least an hour. In the study, people on average, their sessions were 75 minutes long. So it's a long time. Your appointment will be an hour and a half. And you're going to be working that whole time. So you're going to get tired and then you're going to go home and you're going to have a nap. And so that has to be something that you're willing to do. And then you have an ability, we didn't mention this, but you do have ability to work on this at home too. So the kind of cool thing about this device is you get a little magnet and you can swipe it across your chest where the implanted pulse generator is. And that will trigger the therapy to cycle every 10 seconds for a half an hour. And you'll be given an exercise program by your therapist that's customized to you so that you can work on the things that you need to work on. And you're going to do it for half an hour. So you can do that home exercise as well. So you can swipe and you can do that several times a day on the days when you aren't in therapy. So you have to be somebody who's willing to actually work, because you get this thing and you're not willing to work, it's not going to help you. You have to be willing to do the work.
So that's a really key point you brought up about the motivation to move. You have to have you have to be ready to put in the work. And
Mhm.
if you meet some of the qualifiers that you mentioned too, in one being, you mentioned some use a return of distal down at the fingers as well. Is that initial assessment done by some of our stroke survivors, and our therapists obviously will know about, is the Fugl-Meyer, is that how some of that is assessed pre and then post, when you mentioned down the road, when
Mhm.
you looked at the data a year out, some of the outcomes showed that there was twice the
Right.
recovery capacity?
Yeah, so the initial assessments that will be done will probably ideally be with an occupational therapist who will also be the person who's going to treat you. So you want to see that person, that person should do your evaluation so they understand. They will help you understand if you have the level of function that's right. And in addition to that, they do a host of standardized assessments, like the Fugl-Meyer, for example, which is a measure of impairment. So it's kind of the gold standard in stroke recovery. I'm sure you've talked about it all the time with any study that they do. We talk about the Fugl-Meyer. And that is this gold standard of impairment that yes, that's where we saw a doubling of the benefit. And I didn't mention, like you mentioned ISC, but I didn't mention the paper that we're just submitting right now, actually, which is the long-term results. So we have followed these people for a year. We followed these people for a year. And the crossover group, so the group that got the control intervention, they then, after their follow-up, they then got to come back and repeat the whole therapy all over again. So they did another 6 weeks of therapy but this time the VNS was actually being delivered. And those people, they had some gains during that control therapy period, where they just got the therapy without the VNS. But then when they got the VNS and they did the therapy all over again, they matched the level of improvement that the group that originally started with the VNS had. And then we followed these people for a year. So a year after they completed the VNS therapy, and there's no decrement in their gains, which is perhaps the most amazing thing about this study. Because if you follow stroke research at all, you know that what typically happens is, yes, there's an effect. Look, it's a benefit. And because lots of things will give people benefits. But the impressive thing is that this has been maintained. So people, even during, the crazy thing about this is that all these follow-ups happened during COVID. So all of this happened during 2020 and 2021. And so all of the things that were going on in these patients' lives, they didn't reduce their functional ability, which I found really extra astounding. In our pilot project that we'd done a few years prior, we followed people for 1 year and then 2 and then 3 years after the completion of the study. And in that smaller cohort, we found that they actually kept increasing. So their improvements kept getting higher. And it's my guess, my suspicion is that COVID might have dampened some of the potential continued increase that maybe we would have seen had we not been in the midst of a global pandemic. But regardless, it's still very impressive that at a year out, these gains are maintained. So this isn't like a little flash in the pan and then you just go back to your baseline.
That's truly impressive. I'm really great that you brought that up, because you didn't see regression, because you know how hard it is to get those initial changes in function, and to see that's I just have one question. The design of the home protocol, because I know I'm going to forget. Were you involved in that? And is it more task specific, or is it more of is there a rigid, because there's you have to be invested in the time, but also there's also the functional capacity, what's meaningful to that person.
Right.
So when they're home using the Vivistim technology, are they working at things, maybe like you mentioned at the beginning, playing the piano, or just helping with the tasks for cooking? What does that design look like?
Yeah, the whole premise behind the rehabilitation in the clinic, as well as when you're doing it at home, is things that are related to your goals. So the things that you want to improve. And sometimes your goal may be kind of lofty. And so we have to start with a lower level improvement and then work our way up to the more complex improvement. But yes, it's always related to the goals. The great thing about the home program is that it's exactly what you just said. So you could, if you've got a stack of dishes to wash, swipe your magnet and wash those dishes. If if you're going to go out gardening, swipe your magnet and go out gardening. It doesn't have to be sort of a tedious, boring practice. Sometimes it's good to do the tedious, boring thing because you can work really explicitly and focus on something that's really hard for you. But sometimes it's great to just be able to swipe that magnet and use your hand in whatever you're doing.
Yeah, I think the power of having this be, both in clinic and then like managed at home really unlocks, some amazing, outcomes here. And just when you like you have this implantable, right, and you're able to kind of have this intense therapy for the first, what is it, 6 weeks that you're doing it in clinic, and then you're able to do it at home. Like, how long, say someone goes through this, like how long would a patient have the implantable and be able to do some of the at-home therapy for? Is
Yeah,
that like a certain cutoff, or?
Well, that's actually really kind of great about this implant too, is that we don't have to take it out. You can leave it in. So the battery will
Okay.
last about 5 years. So you're going to get this in clinic therapy, and different places do this differently. So in the study, we did it for 6 weeks, 3 times a week for 6 weeks. In the real world, that scheduling is a little bit more flexible. So that therapy may last 6 weeks, and maybe 8-10 weeks, where you're coming into the clinic, but then you're doing the therapy at home too, to keep that level of intensity up. Then you're on your own. Hopefully you're still following up with your occupational therapist once a year or so, check in, try to update your exercise program, that kind of thing. But while you're at home, you're doing all of these tasks, and you have this device and in your body now. You don't have to take it out. It doesn't expire. So you're able to, that's where we can see why, like, for example, in the pilot study where we followed these people for 3 years, they kept using their device. So they'd swipe it and they'd be working on their car. They'd swipe it and they'd be making dinner. So that is something where every time you're using your hand, I like to teach my patients about what it's really doing. Like I like to teach them about how the neurons are firing, because that's, I think, being able to picture what you're doing and why it works, I think helps you to understand what you should be working on, that you want to make those neurons fire. And the more you do it, the stronger that synapse will be. The stronger the synapse is, the stronger the connection is. The stronger the connection is, the easier it is for the brain to make those muscles work.
Now, as exciting as this is, for, I'm sure, the survivor community listening to this, it's equally as exciting for, therapists sitting here saying, wow, like there's this potential, right? Because for so long you've, been working with what you have. Now you have this piece of technology that kind of gets people over the hump. So for therapists, like, what is the process, say someone's listening to this episode now that's interested in maybe applying this to their patient population, what's that process look like?
Yeah.
For whether it's like local or how that's set up right now.
Right. I mean, it does take some effort, because this is a new offering. There isn't anything like this. It was really exciting. There's nothing like this that has ever been in the rehab world before, or this is the first thing for chronic stroke recovery like it. So that's super exciting. But it also comes with challenges, because the health system, whatever health system you are working in, needs to learn how to integrate this into its system. So it does take some work to make some new connections. So the new connect, when we talk about brain connections, there's also like administrative connections, meaning people who are giving the stroke recovery care, rehab, so say occupational therapy, physiatry, they need to be connected to neurosurgery, because the surgeon is the one, well, neurosurgery or ENTs, two kinds of surgeons can put this in. So they need to have the connection with the surgeon who will evaluate, is this person a good candidate from a surgical perspective, right? There's health concerns. So that piece needs to be evaluated as well. So the healthcare provider, they need to get together and talk to each other. So rehabilitation needs to talk to neurosurgery, and they need to figure out a good pipeline or pathway of how can, if I'm an occupational therapist, I'm seeing these patients, how can I refer them to you, and then you get them back into my clinic, so that the therapists who are trained in using the Vivistim system, they can get it on our schedule, and we can have this all flow seamlessly. So it does take some work to figure it out. The how do you do it? In addition to those internal conversations of getting the different players on board and who's going to sort of be the champion within your health system, then you reach out to Microtransponder, which is the company that makes Vivistim, which I don't have a conflict with. I have served as a consultant for them, but I don't have any personal gain associated with this company, except that I've worked with the scientists and researchers for over 10 years, and I have immense respect for the people that I've worked with who've run these studies. So you reach out to the Vivistim system people, the Microtransponder people, and you say, we're interested in becoming a site, and then they work with you to get this implemented.
So there's that intercollaboration, and that's always important in care. I just love that point that you mentioned too, when you're working with someone, a patient, and you see, like, I always get excited when seeing that light bulb moment when they, you drill down to like neuroplasticity, but what's happening at the neuron level when you have them do intentional work and firing. With that said, I'd love to, is there a particular patient or maybe an experience that that you've really impacted your work that you're doing here, specifically with Vivistim and the therapy they're providing?
Yeah, I have several stories that way back when we first did the pilot study. The very first patient that we implanted with this, he was the primary caretaker for his wife, who had some early stage dementia. And so he was highly motivated to get his arm moving again, being able to, he was the primary chef. He really had goals around being able to cook. And he was pretty severe off. He had very little upper extremity function, but the gains that he made might not look dramatic to an outside person, but for him, it was immensely meaningful, because he went from not being able to reliably hold the pot while he was stirring to being able to do that. So the difference of having to try to like stir a pot one-handed and being able to reliably stabilize that pot and stir. Same with using a knife, so he could hold the bread and cut reliably. And the story I tell all the time is the thing that when I asked him, what can you do now that you couldn't do before, that you enjoy the most? He said, shower standing up. So he didn't have great balance, and he couldn't reliably hold the shower bar. So he had to shower on a chair. Didn't like that. To be able to shower standing up was just like this immense, I mean, that's a wonderful feeling, right? To be able to stand and let the water fall all over you. It's it's like our outcome measures. When we talk about the Fugl-Meyer, and there's other ones, yeah, those are important, and we have to have that in research, but that kind of thing, like being able to shower standing up, is not something that our outcome measures always grasp. So that was one example of someone who made a small amount of gain, but that small amount of gain moved him to a next level of independence and function. Now, I have other people who are examples where I literally have never seen somebody with chronic stroke make gains this big. It's just, in my entire career, I've never seen that big of a change in that period of time. And this is the more dramatic gain of somebody who had essentially no reliable function with their impaired hand, to be able to use that hand for regular activities. And the thing that people talk about, like say a year after this has happened, is that one of the dramatic things that happened is that when they realize that they are using their impaired hand without thinking about it. Like, so I just automatically use that hand to reach for the refrigerator door, and I didn't even have to think about it. So that is a dramatic, that's really a really astounding thing to witness. I mean, we also have to be careful to not set an expectation that this is some sort of miracle. You are still going to have hemiparesis. There is still going to be impairment. But it's like, can we get you to that next level so that you can use that hand and that arm in a way that makes a meaningful impact for you? And if you keep using it and keep practicing, can you then just continue to edge up over the long term? This is not an overnight fix. There's no wake up one morning and there's some dramatic change. It is a slog. It's a slow slog, and you measure your progress in terms of months, where you see, okay, let's think about where I was 3 months ago. Okay. And then you keep thinking about it like that, and you can make some really, really big changes.
Yeah, those are beautiful examples, right? And I think like coming out of the rigorous kind of clinical of moving these percentiles of range of motion, right, to real world outcomes of standing in the shower, or say someone being able to hold their baby again, right? Like it's those kind of outcomes that I think really provide that intrinsic motivation for both therapists as well as the survivors to put in the work and look at it in the time span of this not being a quick fix. Although we live in America and everybody loves the quick fix, how do we think this long term? But it's amazing to hear, and I think just lastly we will end on I don't know if we teed this up for you, but we always ask every guest our magic wand question and we'll get to that in a second. But just lastly, as we kind of speak to, you shared some of these outcomes. Before that, we spoke briefly on how hospital systems could get this integrated. There's one other component, obviously, of the complex web. Well, there's probably many complex webs within healthcare, but the reimbursement side of this. And I think that's one of the most exciting angles is that this is now reimbursed. So
Right.
Can you just briefly touch on that? And then we'll get into the magic wand.
Right. So it's not also, this is an easy process. Insurance companies don't necessarily want to pay for new things. I don't know why, because that's another episode. Yeah. But yes, it is a reimbursable surgery as well as the rehabilitation. And there is some kind of misunderstanding in the community, in the rehab community, that that there's a therapy cap that you may use the patient's therapy up, but this is a reimbursable event. And at MGH, where we're doing this, we haven't had any issues with reimbursement. It's different processes in different states, but the microtransponder reimbursement team is phenomenal and super helpful in helping you understand what are the right charges that are associated with these billing codes that are associated with these processes, and can help guide that process.
Awesome. That's unfortunately a big hurdle for many survivors and even therapists trying to navigate, the reimbursement angle. So sounds like a lot of support there. And certainly something that alleviates the pressure of, paying out of pocket. So,
right.
Great. So promised the magic wand question. You alluded to the many issues within stroke care, right? As we started this episode. So, we've, for the past nearly 75 episodes, asked our magic wand question, which is we give you this imaginary, I don't know if David has, sometimes he has the magic wand floating somewhere. There it is. And we would put that in your hands and say, if you could wave this magic wand, how would you take that to redesign the stroke care pathway?
Oh, that's so easy. Every single person with stroke would have access to rehabilitation, maybe like 6 weeks a year of intense rehabilitation, PT, OT, speech, whatever they need. And they would see their therapist once a year. We call it a dental model. Like you go to your dentist twice a year. You'd go into to see your rehab specialist twice a year. You'd get tweaks. Oh, you got this thing that's bugging you. Okay, we should maybe get you this. That rehabilitation specialist would refer you to whoever you might need to see. They would be up on whatever the new potential therapies that you might be a good candidate for to think about. That is 100%. It would change the lives of the 7 million people that are living with stroke today if they could all have access to rehabilitation, in good quality rehabilitation that can just get them maintaining their health. Yeah, absolutely.
And that is such a brilliant answer, because in other neurological conditions we have that. Someone with Parkinson's does see their neurologist a few times a year. To have that sort of that clinic model, or that check-in model that you mentioned, like we do for taking care of our teeth, is such an important thing about maybe changing the standard of care for stroke. And and also to hear about some of the technologies. We sometimes lose connections with our providers when we're not coming back for care. And how else do you find out about changes in technologies that are available, for example, like Vivistim's technology and the work that they're doing as well? So I'm really excited about our discussion today, learning more about this technology and the great potential. And we were happy to be able to have our audience here and meet you and the great work you're doing. And we're also going to follow with, I think, later this month, and we're going to be sharing the lived experience of someone who actually, a patient, has used the Vivistim in their life. So we always like to give you the last word. We want to be mindful of your time this morning, but this has been great. Is there anything you want to leave us with?
I'm just going to re-echo, move. You need to move, you need to work, and you can make great gains. Even without some fancy technology, you can get a lot better. Get some help, find somebody who can help you get over whatever barriers that you are experiencing. There's people out there that can help you get back in to see your doctor and get a referral to therapy.
Well, couldn't have said it better. Fantastic advice. And
Thanks.
I think we'll be getting this out, as we're recording this mid-April, but we'll be releasing this for Stroke Awareness Month in May. And David and I, we've signed up. We're going to be moving ourselves. We're going to be doing a little 5K out in where's that? Canton?
That is Canton, Mass. Yeah.
Yeah. Trillium with Teddy's team and some of the folks
excellent.
over with the SIA group at a Tufts. So, we'll maybe see you there. If you're you said
Yeah.
you enjoy the running, maybe we'll get you down. Yeah.
Absolutely. Yeah. I'm slow, but I can go for a long time.
Slow and steady.
Yeah.
That's my only speed. That's my only
Same,
speed
I
these
got one
days.
speed. Yeah.
Yeah.
Awesome.
Well,
This
it's
was
been a pleasure.
blast.
Thank
Yeah, total pleasure. Thank you both so much.
Thank you.
you. Thank you.
All right.
Take care.
Bye.